not working? How does that sound plug in? So that technology at its finest. Now clicker's working. All right, we're jumping into the skull. We're going to talk about these kinds of things here, skull and spine type stuff. What is your vocabulary? Basilar spondylolisthesis. Spondylolisthesis. Learn how to say that 5 times fast. You will see it often. Here's your anatomy slide, and just look at the X-ray. Right? I'm with you guys. We don't do X-rays a lot on the face and the skull, and this is why. Look at how much superimposition we have on these facial bones, right? Try pulling out the anatomy and figuring out what's fractured where, how, and all of that stuff. It's really, really difficult. So the majority of your facial bone and skull imaging, outside of a couple of instances we'll take a look at, is probably going to be CT. Just because I need to see all the detail, as I did call out of this. I need to see all the detail, and I can't look at everything in this anatomy photo and be able to correlate it with the X-ray, right? Here's my lateral, same concept, right? Where are my sutures? They're kind of there, but like, where does stuff end and begin? X-ray is not a good study when looking at the bones of the face, except for like nasal fractures sometimes, but most of the time when you do an X-ray for a broken nose, no, treatment's gonna be the same. Whether they actually broke that little nasal bone or not, you're going to treat it the same unless there's breathing issues. But, so we do CTs because now, again, look at my X-ray and look at the detail I have on the CT. Now on the CT, I can make out the zygomatic arches. I can make out the full orbits. I can even see my ethmoid sinuses sitting in here. Zygomatic arches, part of the skull. If I go laterally, I can make out the entire skull. I can see the part of the mandible down here, part of the maxilla up here. I go down here, I got mastoid air cells. So here's my mastoid air cells. Right? Even get into the ear and the auditory canal area. So you can see how much detail the CT is going to give us on these facial bone concerns as opposed to the X-ray. So the majority of your facial injuries, if you're concerned about fracture of the facial bones, you're going to jump to a CT instead of an X-ray. But we can still have fractures in the skull. So, what kind of fractures do we have? Linear is your most common, straight across the flat bones. You can get your depressed fracture, where the skull is actually depressed. You'll see what that looks like on X-ray, causing potential brain injury. Then you get your basilar fractures, which is in the bottom right-hand corner here. This is the most concerning because we lose that stability with that C1, C2 potentially, with the basilar fracture, so these are really concerning as well. But ultimately, a CT without contrast, our non-con, is your initial study of choice. Well, wait, that's initial and study of choice? Yes, it's both. It's the first thing you're going to go to, and it is your study of choice in acute head trauma for 2 reasons. One, I get the details of all the facial bones and all those little fractures. Imagine trying to find a basilar fracture on an X-ray. Right? I got maxilla, mandible, teeth, all this other stuff in the way, and it's going to make it really hard to see. But if I get a CT, I can find that. Yes, sir?
So would contrast just cause unnecessary illumination?
Not unnecessary illumination. We will talk about why we don't do contrast in a few slides. I don't want to break that punchline yet. Okay? No, it's okay. I like that you're thinking that because you want to know kind of what's going on. We talk about all these CTs with contrast. Why wouldn't I want it in the head? And we will talk about that here in just a little bit. So, non-con is your study of choice for acute head trauma. Here are some X-rays, right? So you can see a depressed fracture. We can see pretty well on the X-ray. You can see the fracture here and here. The skull is supposed to be rounded, like this is my normal here. This is my normal. And then I'm depressed posteriorly. Or up here on the top, also depressed. 2 different X-rays, both showing depressed fractures. So now you can see that he has one, but I also don't know the extent of that damage on just an X-ray. I just know he's got a depressed skull fracture. Okay? The non-contrast CT is a study of choice to evaluate for trauma and bleeding. blood has a different appearance based on the length of time of the bleed. Your acute bleeds are going to show up white, which is why we don't do contrast, because contrast also shows up what color? White. So if I give contrast in the brain, I don't know what's a highlighted vessel and what's a bleed, because I have white on both. So that's the reason we don't do contrast in the head, is so we can see if there's an acute bleed or not, and if we do, we know that's blood. Why does it show up white but it's gray on everything else? It has something to do with the contrast of the gray matter, the white matter, the gray matter, and the density of the blood, which is why acute bleeds are white. Subacute, kind of the same color as the tissue, right? And then when we get to the chronic, it's basically like that clotting, it's like a thicker kind of density, so it's darker than the surrounding tissue. And that's just how it works in the brain. It has to do with the brain matter and the density of that tissue compared to the rest of the body, of why the fresh acute, we call it liquid blood, right? Thin blood shows up as bright white on those CT scans. So here's an example of the three. I have an acute bleed here with the white solid arrow on alpha. This is my acute bleed. It is brighter than the surrounding brain tissue. Okay, now I draw your attention to the chronic bleed, darker than the surrounding brain tissue. We'll get to the dotted arrow here in a second. And now look at Bravo and try to find that subacute isodense. I really can't. This is the stage when it's there, I'm trying to show it to you, but it's really, really hard to make out. This is the stage when that density is very similar to that brain tissue, so it kind of doesn't really show up very well. But this is why we don't give the contrast, because if we did, I wouldn't know that's blood. This would all be lit up. What the white dotted arrows are showing you is what we call a midline shift. So we got one ventricle here, one ventricle here. Here's the start of the midline, and I should be able to just draw a line straight down, and one should be on each side. One should be on each side, but it's not. I have a shift, and that's from the pressure of the bleeds. It can push and shift things over. So there's two ways to notice if there should be a head bleed or something, or a mass in the brain. One, I can see the blood, see the acute bleed. Two, even if I can't, do I have a midline shift? Because if I do, something's pushing that over, right? The head is this nice contained area. It's only got enough room for the brain and the vessels and the CSF, and that's about it. If something's there that's not supposed to be there, it's going to push it over. It's soft, it's squishy, it goes right over. We'll see more of these. There are different types of hemorrhages that you're going to be able to diagnose specifically based off of symptoms and the way the CT looks. But before we go that, let me go back to this. In Alpha and Charlie, which side is the bleed on? Patient's right. CTs work the same as x-rays. I don't have a right and left marker here. In most CTs, you don't get one. But we know my left is the patient's right, my right is the patient's left. This is a right-sided bleed. So you can call that with just the image. Okay. So, intracerebral hemorrhage, right? There's all your risk factors. Hypertension, current smoking, excessive alcohol consumption, old age, males, Asian ethnicity, chronic kidney disease. And they're basically just like America, right? Top three, America. Most of us, not us in this room hopefully, but Americans down the road. Alright, so what happens is we get trauma, usually is one of the causes, injuries occurring at the point of impact, whether it's that depressed fracture, whether it's falling and hitting their head or something along those lines. You can get aneurysms, vascular malformations. The biggest thing with the intracerebral hemorrhages is the CT findings change over time. And so like, you may get a head CT and it look fine. It look fine. But then you come in for a follow-up and you get another one, and now it's presenting with some of the hemorrhages. Because the intracranial hemorrhages are kind of slow, they're not as quick as some of these other ones we're going to look at. You can get cerebral contusions in the brain as well, and that can kind of show up a little bit. The sub-bullet underneath the first one, which talks about MRIs, demonstrating lesions from time of injury. Yes, MRIs can be better at finding small bleeds. MRIs can also be better at finding TIAs or mini strokes. But if it's that small where it doesn't show up on CT, is it emergent? Probably not, right? You can't get an MRI on an emergency basis. And that MRI is still 45-minute scan, whereas this CT, they're gonna be in and out in 30 seconds. The scan's that quick. You may have blood inside the ventricles, okay? And then that mass effect, that's what that pushing is of the objects. Mass effect is common in most of these bleeds. The mass is affecting the ventricles and pushing things over. So here's a couple of examples. So you can see the cerebral contusions and the hemorrhage right up here at the top. It's these bright white circles. You're like, how am I pulling that out? Look at the rest of the brain matter. Look at the rest of the brain tissue. It looks different. It's brighter than the surrounding tissue. Okay? Down here in the bottom, this is that intraventricular hemorrhage I was talking about. The dark area is filled with cerebral spinal fluid. This is blood because it's white. And this is another reason why we don't give contrast in head CTs. I want to know that that is not contrast down here. And if I give contrast, I can't make the two out. Okay. Here's the intracerebral hemorrhage. This is from the damage in the skull fracture, right? If I follow my skull bone all the way around and I come in here, I got my fracture, I got my swelling from the injury, and now I'm bleeding into the intracerebral area. Fracture, swelling, bleeding, and then I'm starting to get some of that mass effect shift. The white dotted arrow is showing the subarachnoid area kind of getting shifted over to the other side. So going back to the intracerebral hemorrhages, hypertension, current smoking, excessive alcohol consumption, probably some form of trauma. It's going to be your intracerebrals. And not only that, where's all my blood? Inside the brain matter, inside the brain tissue, right? Intracerebral. These other ones we're going to see have a specific shape to them that is different. This is the one that can be anywhere. Subdural. Elderly, alcoholism, anticoagulation. What kind of patients are going to be on anticoagulation? Could be elderly, right? Primarily those who are at high risk of, right, blood clots. Maybe they had a prior PE, right? You know, a patient, older patient, was a smoker, had a prior pulmonary embolism, has a history of DVT, something along those lines that is going to cause them to be at more of a risk of having having blood clots or some kind of clotting disorder. They'll be on anticoagulation meds. What happens here is they get cranial trauma, results in the subdural hemorrhage, and it's the bridging veins between the dura and the surface of the brain. So go back to our anatomy from last semester. Think about how that kind of lies and sits in those little cavities or the different layers, right? So it's between the dura and the surface of the brain. We'll see what that looks like in a picture in a second, right? Acute is a rapid progression of headache and irritability. Okay? Sudden headache kind of came on. We're not talking worst headache of life, that's a different brain bleed. We'll get to that in a little bit. But just all of a sudden, I was sitting here and I got this really bad headache, kind of came out of nowhere. Okay? It's a crescent-shaped hematoma. So we have elderly, alcoholics, possible anticoagulation. So if a patient vignette, I tell you a patient is 77 and they're on anticoagulation meds, right? Okay, those are clues, those are hints to try to help you distinguish between some of these bleeds. But in reality, all you really need is the picture. And here's why. It's a crescent-shaped bleed. So here's my bright white right here. You can think crescent shape, or you can think that the shape of the bleed follows the shape of the skull, right? Because of where this bleed is, right? It's between the dura and the surface of the brain. So it's being contained kind of right in that area. It's going to follow the shape of the skull. So all of them are going to follow the shape of the skull on the scan. So it's that crescent shape, subdural hemorrhage, right in there. Now when you get into your isodensophronic, so this one is kind of right here. This is my chronic older bleed. It starts up in this area, follows it, but I'm starting to get that mass effect. It's right in here, and starting to shift over. Most of the bleeds I'm going to give you on the test are gonna be acute bleeds. Why do I wanna give you acute bleeds? Because at this stage, I need you to recognize acute bleeds. Because those are the patients we need to act on. You'll learn how to act on them in neuro, in EMED, in surgery, and all that stuff. But you can't act on it if you don't notice it, right? So I will be giving you acute bleeds. I'm not gonna try to get you with like this little isodense or chronic type bleed on a head CT. That's not a benefit for you at this stage, all right? So just know that crescent shape follows the shape of the skull. That's gonna be your subdural. Epidural. Middle meningeal artery rupture. Now we're having blood accumulation between the skull and the dura. So in a different layer, which means it's going to be shaped differently because of the anatomy. This one's interesting though because you get headache just like the last one. You get vomiting, you could have that in the other one too, but you end up with loss of consciousness, and more importantly, what's more of a telltale sign of it is you get a period of lucency in between it. So they lose consciousness, they wake up, they're talking, yeah, that is really bad headache. They're talking to you, everything's going okay, and they lose consciousness again. They go in and out of consciousness. They have that weird period of lucency. It's variable. There's no specific timing for how long or what the gap is in between the two loss of consciousness episodes. But usually they do wake up too. They're kind of like, they don't really know what's going on. Like, what am I doing here? It's not automatic. Not everybody with an epidural bleed has that. But this is the bleed that if they present that way, the one you need to be concerned about, because this is the one that acts like that. All right? CT head non-con, your focal bleed is going to come from the middle meningeal artery. Now you're going to have a convex lens appearance. At the risk of certain people in this class taking a shot at me and bringing up football, it's going to be a football-shaped bleed on the side of the head back here. Don't act like you weren't scared for 3.5 quarters. All right.
I'm just turned off.
So this one's different, right? It bows out, or bows out, whatever English word you want to use. But this is a kind of a football-shaped, right? Convex lens bleed in the same area, but this doesn't follow the line of the skull. This is opposite, right? So if I go back to my subdural, look, goes along with, the edge of the bleed follows with the shape of the skull. This one bows out. Everybody tracking that? Along with the patient presentation of how things are going. Okay. Here is a slide that I made for you guys because I like you, and I just want to put both of them side by side for you. Okay? What causes it? First of all, trauma in most cases, but one bleed comes from the bridging veins. The other bleed comes from the meningeal artery. So one's a venous bleed, one's an arterial bleed. One is concave, one is convex. Elderly, alcoholics, deceleration injury like a car accident, but really any kind of head trauma can cause these. Lucid interval, loss of consciousness, normal, loss of consciousness. Perfect slide for you guys to kind of study that and associate between the two. Now if that were it, that would be good, but now we got to talk about this guy. Initial study of choice, go CT non-con. This is your subarachnoid. Why is it subarachnoid? Well, it's in that area, but I, from a teaching standpoint and understanding it, like to go, hey, the blood is in the center and it looks like a little spider in the brain. Arachnoid, arachnid, right? It looks like a spider with all its little legs. Notice how it's not along the edge. It's sitting right in that area, right in here. Okay? This is the one, that thunderclap headache. This is the worst headache of my life. This is why you have to ask the patient, every patient who comes in, I don't care if they're a migraine patient and they're a chronic migraine patient and they're just coming in because their headache is bad today and they're looking for their shot of Toradol and their IV because they can't go to work and they got a migraine, you've got to ask, is this the worst headache of your life? Every single patient who comes in with vision issues or headaches, you have to ask and document that. Because if they say yes, Even though they're a chronic migraine patient, they bought themselves a CT to make sure it's not a subarachnoid hemorrhage. If they say no, then great. Yes, ma'am.
So the headache is only gonna be on one side.
What's that?
So for the headache, like for this case, it's gonna be only on one side of the head, or it's gonna be like all around?
Not necessarily. It depends. Where's the headache going to be? It could be unilateral. It could be bilateral. There's no magic like it's just one area or not. Right? Which is why when these patients come in with migraines, a lot of the migraines are unilateral. It's just, if it's a headache, ask the question. Don't miss a subarachnoid hemorrhage. If you're in the ER, right? Because you're not going to do a lumbar puncture in the outpatient setting. That's not going to happen. But if you're in the ER and you get someone that comes in and you're like, this is subarachnoid hemorrhage. It looks like a duck, talks like a duck, smells like a duck, it's probably a duck. And you go get your CT scan and it's negative. But you still have a significantly high suspicion for subarachnoid hemorrhage, lumbar puncture. Because what else is in here besides blood that we can't see? CSF. There will be red blood cells in the cerebrospinal fluid. That lumbar puncture will tell you whether or not there's even a little bit of blood sitting in there and then you can get picked up on CT. That's a rare situation, won't happen like that very often, but there are a few things to where like and for those of you who are guard reserve in here, if you're gonna go out and you're gonna work in the ER, right, you're gonna get this patient who comes in, worst headache of life, vomiting, altered level of consciousness, right, maybe they're in and out, maybe they seem like they're delirious or whatever, and you're pretty confident on this, and you get the CT and it's negative, but you still think that's what it is, get the lumbar puncture. Verify that. But subarachnoid, biggest thing for you guys, recognizing the thunderclap, worst headache of life, CT non-con, and then where it's at, the little arachnoid shaper there. Questions on any of the brain bleeds? Okay. Facial fractures, kind of blew the punchline in the beginning, but CT is going to be the initial and study of choice for facial fractures. Too difficult to see with X-ray. Your most common fracture is your orbital fracture and the blowout fracture, right? Usually caused by what, do you think? Same things those human bites get caused by, right? Bar fights. Just because we're the Department of War now doesn't mean you need to go out there trying to find fights in the bars, it doesn't matter. But blowout fracture of the orbital floor. Now you don't always need a CT to diagnose this because what you'll end up happening sometimes is you'll get entrapment of that inferior rectus muscle, which means the eye, like an eye look like they kind of have like a lazy eye, but it'll be like an upward gaze and you'll have double vision. That's in the diplopia because that muscle gets caught in the orbit where that fracture is. So if you see that, they got in a bar fight, I mean, you're still going to get the CT to make sure there's no damage, but you know they at least have an orbital fracture that's capturing that inferior rectus muscle. You can see lots of findings on CT. I'll leave that there for you guys. You can see blood in the sinuses, emphysema in the orbits, right? Fracture through the floor of the orbits. This is kind of what it's going to look like. So, look at the normal X-ray. And I know it's normal, but how well are you making out those orbits? Not very well. But the CT can show you the difference. This is the normal side. This is the abnormal side. Normal side, abnormal side. So you should have a nice round orbit. Here I have the gap. Not only that, I got fluid. This is not the eyeball leaking out into the sinuses. This is blood and fluid leaking out into the maxillary sinuses down in here. And here's another example of that fracture on another slice. Got some fluid coming down in here. Also got some fluid, kind of blood building up in the ethmoid sinuses here. Look at the difference. The nice part about a CT is look at how I can compare the left and right next to each other. Got these good air cells and good airways in the ethmoid, and then it's like all clogged up sitting in here. Likely blood from the fracture, from the punch or the fight or whatever it was. So this is why we get CTs for facial stuff. That's all you really need to know about facial. Most common in the order of CT. Now your fracture classifications. Alright, here's a practice one to kind of take a look at. Again, I got air fluid levels in my maxillary sinus. So it's not, can't see it on this slice dripping down here from the orbit. Can't really see that, but I do see this level of fluid that's not in the other one. So that's probably blood, and then look at my ethmoids compared the two together. Right? It's all about comparison. Bleeds. So what kind of bleed is this? Subdural, there we go. There we go. We got an acute one over here, we got a chronic one over here. But now look at that midline shift, right? Let's say we didn't see the chronic. Let's say we didn't see the acute even. If I do my midline, look at this. I go straight down. I got part of this ventricle spreading over midline over this way where it shouldn't be there. I should have one ventricle, one ventricle. Here, this one over here, I got a whole ventricle there, but my midline is kind of like this. It kind of comes down like that. But you can see the mass, and it's all pushing and bulging over. It's that mass effect. Kind is this one? Epidural, little football. Questions on head bleeds or facial bones? Give me 30 seconds. All right. Ow. These are the kind of patients you'll see in phase 2. Some of you more than others, depending on where you go. What's going on here? From a medicine standpoint. Yeah, so we're checking for pelvic fracture, right? So he's looking for crepitus, he's looking for the old classic open book, closed book type pelvis. Don't really do that too much anymore, as far as like calling it that and treating it that way, but that is exactly what he's doing. He's trying to see if there's any shifting in the pelvic stuff. We're going to talk about pelvic fractures here today. More spine and pelvis. Okay. Spine first though. 80% of all Americans will have some back pain. Low back pain is the #1 medical diagnosis in this country. More than heart disease, more than hypertension, more than high cholesterol, more than anything else, low back pain. The majority of low back pain is just muscular. Usually due to poor lifestyle choices. But it is the #1 diagnosis in America. So you will see a lot of low back pain. A lot. We're going to talk about all of these things. Some things we already kind of talked about, like ankylosing spondylitis. It'll be kind of a review. But we're going to talk about all of the different spine abnormalities. Cervical, all the way down to the pelvis. Here's your anatomy. It's the spine. More anatomy there. Understand that we have our discs, right? That annulus fibrosis, nucleus pulposus. That's important to know because we're going to talk about herniated disc dissection and how we can diagnose that. Which level of spine, though, has the greatest space between their discs? Right? Lumbar. Larger. Segue to talk about the cervical. Makes sense. Alright, so there's your cervical spine anatomy. So take a look at a couple of things here. We're going to go over lines and tracing things, but understand what normal looks like before you even get to the x-ray. Understand all the different parts of the spine. Because when you're looking at it, you want to see how these things sit on one another, especially in the lateral view, to make sure you get kind of the spinous processes, what the space should be, how everything lines up. Notice how the front of the vertebrae are all lined up in a nice pretty little line. We're going to go over the lines of how you kind of trace in your mind's eye and x-ray to make sure everything looks good and is in alignment for a cervical spine, a lumbar spine, all of that stuff. Muscles. We're not really covering muscles in this course, but since most of your neck and back pain is due to muscular issues, these are really helpful when you're doing your physical exam if you can remember where your trapezoid is, or your trapezius, or your scalenes, or your sternocleidomastoids, because you can give handouts on stretching techniques and things like that to the patients so they don't have to go see physical therapy or whatever they can get them back to work. But Here's your muscles. All right, so here is your normal x-ray. What's the first thing that jumps out to you as, that's a concern, that's an issue? This is normal. What can't I see? Right? Okay, so I can't see the spinous processes, that's fair. I'll give you that. What else can't I see? I heard it. I'm missing C1 through C3. I can't see it on an AP. Why? I got a big ass mandible sitting right there. Right? So the challenge with spine sometimes, especially the C-spine, which is why we'll do CT for a lot of stuff too, is that I can't see it all in one picture, especially when it comes to the C-spine. Right? So I need multiple pictures in order to view it all. But I've labeled it for you here. But theoretically, with an AP cervical spine, you should be able to tell me which vertebrae is C5, even if I didn't label it. How do you think you might be able to do that? What would be your point of landmark be? And if I'm spending time going over this, there's a reason for that. What do you think your landmark point would be on this particular x-ray if I didn't have it labeled to make sure you're counting your vertebrae correctly? T1, I think I heard that, T1, right? Where the ribs come in. The last vertebrae where ribs come in is T1. Even if it's not labeled, you're like, I know the thoracic vertebrae have ribs. It's the only vertebrae that have ribs. So since I can follow ribs up and I can see ribs coming in right here, ribs coming in, that's T1, and now I can go C7, C6, C5, C4, and I can count up from T1. Okay. Spinous processes are right down here in the center. Why is it in the center I have this large radiolucency going down the center of my cervical spine? What is that? Not the esophagus. Trachea. Trachea is filled with air. Esophagus is not. Right? Trachea is filled with air. So that is my trachea coming down here. The nice part about it is I like that because it makes those spinous processes pop, so as I'm counting up, I can see those as well. But that is my trachea sitting there. These little bright white guys right here, these are your pedicles right on the side. Got one labeled there. These are your pedicles right here. But this is your AP cervical spine x-ray. You're going to get C7 up to about C4, sometimes C3. It just depends on the patient. Aha! Now I can see all the way 1 through 3. So now, if I were going to try to count and say, tell me which vertebrae is C4, what's going to be your point of landmark for starting? Not T1. And here's why not T1. This is a really good cervical spine x-ray. To the point to where they did a great job getting the patient to depress the shoulders down to be able to get C7 and all of T1. This is rare. Most of the time T1 is obscured, and sometimes that C7, T1 disc space is obscured, especially in either your really muscular patients or your really large patients. They can't get those shoulders down because the x-ray is coming in this way. So if I got a bunch of shoulder here and I can't get the shoulder to press down, all the radiation is going to go in there, and I'm not going to be able to see a lot of this. But we can use our first spinous process below the skulls, I heard somebody say, as C1. And so we can go, all right, well there's 1, 2, 3, and there's 4. And you count down on the lateral. 1, 2, 3, and 4. So you count down on the lateral starting from the top, because I can see the base of the skull and I can see that first spinous process. Okay? But from the AP, we count up from T1. Because I can't promise you that this is going to be really clear on all of your x-rays. Now theoretically, if they shoot the x-ray and they haven't gotten all of C7 and that disc space, they're supposed to do it again. Because to get a true cervical spine x-ray, you need all of the vertebrae of the cervical spine. But some patients aren't going to be able to do it. And they're just gonna do the best they can. Okay, here again, we have our trachea coming down. Trachea coming down here. Notice I'm pointing out the intervertebral discs. Do you see anything there? Yeah. There's nothing there. It's all soft tissue. Like it's there, but it's not visible on X-ray. It's not visible on X-ray. If you want to see an intervertebral disc for some reason, you're gonna have to get an MRI, and we'll look at some of that later. But it's not visible on X-ray, so it looks like these guys are just kind of floating. But in reality, there is that disc that's sitting in there that's giving that cushioning and that spacing. I think that's most of what we got from the lateral for right now. You can get these obliques. The obliques do a really good job of showing you the intervertebral foramen. Right here. These nice open intervertebral foramen all kind of sitting there. We're going to look at, well actually we got it right here. You can see the difference. So here's my normal, and my normal, look how nice and open those intervertebral foramen are on my cervical spine. And now go over here and look at my guy. This is somebody with like degenerative disc disease. They have a little bit of arthritis in the cervical spine. And you can see how the osteophytes are starting to come in. A couple of these are open and nice, but then they start to close down in some of these areas. So I'm kind of open here, but then as I get here, they get smaller. But on my normal, they all look pretty similar and all look pretty much the same. That can cause some significant radiculopathy and pain because the nerves and the vessels roll through there. And so when you get these osteophytes or this kind of inflammation stuff going on in here, it rubs up against those nerves and can cause some neuropathic pain. We'll see other pictures with actual, like really bad ones so you kind of get an idea. But we don't order obliques too often, but this is the best view to look for those osteophytes or that arthritis of the cervical spine if you're concerned about that. Now, how do we look at it? So we went through our stepwise process for all the other x-rays, and you still got to do that here, but now you got to do something a little bit extra. You got your four lines here that you have to follow. And all of these lines should be fairly smooth and in a straight / kind of curvilinear aspect. In other words, I don't want any step-offs like this. I want it to come down and then go in and then come down some more, right? Or come down and go out and then come down some more. It should be a nice, smooth, in this case, lordotic point of view. In the thoracic spine, kyphotic, and then lumbar, again, lordotic, right? So what we're doing is we're tracing the anterior vertebral line all the way down, making sure they're all lined up one on top of another like they're supposed to be. Then we do the same thing posteriorly with the posterior vertebral bodies. Trace it all the way down, make sure everything's lined up the way it's supposed to. Then you can do your spinal laminar line, so just in front of the spinous processes is where the lamina are. We do the same thing, all the way down. And as you see as we get back, right, it's more kind of lordotic, but as long as it's a nice, smooth kind of shape going all the way down, we're okay. And then we have our spinous process line, posterior spinous line, following the spinous processes. This tells us the alignment of the spine is okay. And this is the same thing for the thoracic, the same thing for the lumbar. You're looking to make sure everything is lined up the way it's supposed to be, outside of just looking for fractures. Because you can have, and we will talk about this, you can have slippages of these vertebrae, but there'll be no fracture. This is how you can tell everything's lined up the way it's supposed to, is by following these lines. Here's another one. Okay. Another one showing you that, and then I got a CT to show you kind of how it correlates there. How do I know it's a CT? Well, I have a spinal column here, and I just got this gray kind of one density thing. I can't make up spinal cord from CSF or anything like that. This is all just soft tissue and fluid in there. I know the spinal cord and the CSF is in there, but I can't tell the difference. So that's my CT. It just goes to show you those lines. Here's one you can do on the AP. I mean, you don't get a whole lot of left and right shift of the vertebrae, to be honest. But you can technically still do the same thing. Spinous processes compared to the two sides of the vertebral bodies. And then there's this guy. Right? So, saw in the AP how I couldn't really see that C1, C2 area. On the lateral, I got one, but there's this really important guy sitting right in here that I couldn't really see on the lateral either. So how do we get this picture? So this is called an odontoid view. We don't do it very much unless you don't have a CT scanner, because in order for a good picture, these are some of the best ones you'll probably ever see, because in order for a good picture, I need my entire C2 indents, I need both the lateral masses of C1 and the full joint space in between both of those. So this is a perfect odontoid view. Most of the time, you got the teeth coming down here hiding the lateral masses, or the teeth are up here hiding the main body of C2, or the front tooth is cutting off part of the dens, and you're like, I can't make out all of this, which is why we'll jump to CT if the patient is stable, because we can get that detail, like with the facial bones, of all of those guys. Because what we're concerned about, especially with neck injuries, is a fracture to the odontoid. Right? Fractures to the odontoid are going to go ahead and cause instability in that cervical spine, depending where it's at. It may be surgical, it may be not, but that's what we're trying to find. And sometimes CT can be hard to do that if you don't get it, or sorry, X-ray can be hard to do that if you don't get a good enough picture. Which is why it is antiquated, but if you're ever in a place and your CT scanner is down, this is what you're gonna need to get. I'm not gonna test you on this, but this is another one of those things, you're gonna get that report back from radiology, and they're gonna say type 1, type 2, or type 3. This is one of those rare instances where the larger fracture is not the worst case scenario. So as we go up in type, the less concerned we are on your odontoid fractures. This is extremely unstable with just this little tip here. This one here, we can keep it in a C-collar. That's down to the main body of the vertebrae. That's going to heal real nicely. It's going to be in a collar for a while, but it's going to heal real well. That tip of that odontoid, not so much. So, if I were to ask you, even though it's an FYI, what type would this be? Look at that. 2. Right at the base of that dens. Right there. Doesn't quite go into the body. Doesn't quite go into the body. It's just sitting right at the top there. Okay. Alright, so normal CT, again, get the bony structures more clearly. This is why we do this. Look at how much detail I can get on this odontoid and on the interaction between the lateral masses, and it has nothing to do with patient positioning and how well they open their mouth or not. I'm just scanning this slice going straight in, right? And then I got my nice little sagittal slices here, so I can do my fun little lines that I just learned to make sure everything's lining up appropriately, all the vertebrae where they're supposed to be. I can utilize this to make sure there's no fracture of my dens or my lateral masses. And I got a nice, clear imaging to be able to clear this patient and say, you can take off your C-collar, we don't have a fracture, we don't have any of the vertebrae, you're good to take it off. There's your MRI. Look at the difference. CT, MRI. Spinal cord, CSF, intervertebral discs. Everybody see that? Sagittal MRI. Not in the emergent setting, but something that will help see some of those other areas. Now I put them side by side for you, so you can see the difference. Questions on that so far? Do the next slide. Yeah, I'll do one more. All right, so normal MRI again. Showing you some areas of this. I'm not going to make you dictate the MRI, but you can even make out the vertebral arteries, okay, the nerve root. So this darker little area coming off of the spine here, that's a nerve root right there. That's the main spinal cord area, right here. And then this is the CSF around it. So you can actually see on the MRI, on patients that have like nerve root impingements, you'll be able to see that, or the radiologist will be able to see that necessarily. You guys might be able to, especially if you didn't know where to go, but that's why MRI can be so valuable, especially with those ridiculous symptoms, those nerve type pain. When the x-rays look normal and everything looks fine, MRI can sometimes be very beneficial in that aspect. All right, take 10, come back at 3:40, we'll jump into the next section. Oh yeah, of course. I haven't, so I usually start to actually great to talk about. Yeah, nothing changes. Looking a lot
How dare we not have to finish this one? How dare we?
yeah, so if somebody gets done early, I'm very nice. Always comes
I wouldn't yell at you. I'll probably roll my eyes.
I would be an asshole for my views, because I think it's funny. Not because I like it. Not because I think it's nice to be. As long as they try to make sure that I know you are. Well, I think there's some truth. Yesterday, he was like,
great. This is how that's why I always say, really, for us, we don't even usually need to add to that. It's just the way we're like, maybe like, hey, the thing about it, she was like, well, this is how I follow it.
I just don't ever want to come across.
How for that, what else? I just don't want to know about this stuff, right? So just look at what is helping out with very I just say just shoot hey.
Definitely.
No. Antiquated view, it's like antique. It means it's a view that we don't really feel easy. We don't do that at trades. It's old news. Because we have CT now. So we just do CT. If you don't have a CT, you need a DVD. So yeah, it's more like her or like old Wells.
I just love how like how do you get peak time? I was like, everyone else is fine.
Like one direction.
Yeah, no, we're good.
You know what it means? Oh, it's a term. It's gonna be it's slang for being linked with bubble.
I don't know about the salad. I can't.
Why is
I don't know. I don't know.
why it's called.
I don't know. I don't know the salad. There's lots of different metaphors.
Why that's done intentionally? Because guess what you can use that time for?
There was one time. That was bad.
I don't want to think about like, well, salad's green.
Maybe the texture. Our class is here.
I don't even know. I don't even know how people. I thought people just ate salad.
So because we have one color,
Where?
for PAA, every class.
Yeah.
Yeah, what
Yeah.
or on your wrist. It could be just like.
What are you talking about?
That's what I mean. Yeah. Could have gotten that.
Wait a minute, you want to know?
I do feel like
think everything's a build, so I think after was one for like 7 more minutes. So then now it's just like my tuning it and putting like I think they're just like gradually it's a lot of slides. Rappers say eating groceries.
Apparently, it's not a main topic for Georgia.
Really, I think it was a long because they eat suck.
So what I used to do, I stayed here. You guys got some issues to fix.
I think it was
Because
if we were down our top two defensive backs and still had held JJ to 4 yards until the fourth quarter, Justin Jefferson, like that's a problem. That's a problem.
He was holding on to the ball too long. He was still thinking it was college.
But I'm just saying in general, just holding like Jefferson, like that wasn't even close to our best defense, right? And then it took the fact that our guys wore out a little bit. I mean, there's no excuse for 3 touchdowns. And really, maybe he should have kicked the field goal instead of going for 43. They should have kicked the ball out of the end zone on that last kickoff, or out of bounds, not out of the end zone. Take the penalty, take the 40.
It's why you don't know. Because then you get an extra. Instead of 15 seconds, or if they have a clock, maybe they have 35. Like, no, actually, they have 48 seconds. And they don't have like one play that's just basically or
Yeah, that pick six was super expensive. That pick six, I don't even know what it's called.
All right, let's take our seats.
Yeah.
You just saw guys rushing in his face when he threw the ball. All right. So, a couple of questions. I'll kind of give advice unsolicited, but hey, you all be you, right? So, things I get from the break that I think could be beneficial to everybody else. So somebody was asking, hey, stuff for the test, questions like, hey, images would be supplemental, right? Adjunct. So we'll always have anything yet? Not necessarily, right? I throw a picture up there and ask you to describe a fracture, or asking you to tell me what kind of fracture it is. You don't need a vignette to pull out a green stick fracture. You don't need a vignette to describe an oblique or a transverse, or name a dislocation or a displacement or something along those lines. What do you need vignettes for? Well, I'd like to give you a vignette with a lot of the arthritises, because some of those can look pretty similar, right? I'd like to give you a vignette with some of the head bleeds. So the things that can look similar, that you would use some of those symptoms and those history and presentation to help you figure out which one is most likely, that's where your vignettes are going to come into play. Now, when we get into block 2, there'll be many more vignettes, because again, the chest, a lot of things look similar in that aspect. Questions on that? That clear it up? Hopefully, not really? Okay, we'll talk more about that as we get on. There are 2 lecture blocks left. I have this, and then those 2 really long slide throughs. Don't stress, I'm not gonna fly through if we don't need to, because the way I've structured this block, I don't need 2 hours for the lab, right? Which means if we get a little behind because you guys have questions or make sure you understand it, I have time in that lab block to be able to make it up and get through the lab, not a problem. So we're not even at a stage where we gotta worry about rushing through that stuff. So if you're stressed about that, curve that to the side, it's gonna be okay, I'll go however slow I need to go. And I have that extra time built into that lab, it's not a 2-hour lab, okay? Also, I saw a lot of the schedule changes. Looks like you guys are juniors for like the next 4 or 5 weeks, right? Yeah. 1,700 days are long days. How many of you live not on base? Yeah, right? How many at 1,700 sit in traffic for like an hour trying to get home? A good portion of you, right? 45 minutes, hour, whatever the case is. I don't know what your family situations are. I don't know what your routine is. I don't know what your schedule is. But as you saw with the junior semester, it's like this almost the whole time, right? So, recommendation, that's all it is. You sit in traffic, that's time wasted sitting in traffic, right? Can't really study in traffic unless you got it recorded and you're listening to it like a podcast or whatever, but that's time wasted. So what I used to do, so my class used to do on those 1,700 days is class would end, we'd take a little bit of break, and we'd stay here. Or we'd go downstairs outside. Or we'd go to the Starbucks down on Riddeman and Wurzbach. And we would use that hour that we were sitting in traffic to study right afterwards. Let traffic die down, then do our normal drive home, do our dinner, family time, and start studying again. It was at least, because once you get home at the end of the day, I don't know about you guys, but for me it was like, I get in, the kids and whatever, it's like, oh, I'm home, and you kind of don't even get to study until after dinner anyways, right? But for those of you that are doing that, it might behoove you to use that traffic time on these 1700 days, maybe here, or somewhere close by, letting that traffic die down so the time is more value added, as opposed to wasted just sitting there cussing out all San Antonio drivers. So, just a thought. Up to you guys. You're all adults. You're all gonna pass anyways, so however you do it is how you do it. Okay. Let's jump back in. What is the importance of the three or four vertical lines used to assess the images? Making sure everything's in alignment, right? There's no shifting of those vertebrae. We're gonna see some x-rays on what that looks like. Or pick out the talking cervical spine. Right? So these are your osteophytes. These are growths off the front of that vertebrae. Again, one of the signs of possibly like degenerative disc disease or arthritis of the cervical spine. These are anterior bone spurs. How do I know it's an abnormality? Well, because when I do my anterior vertebral line, I draw like a little hump there, right? It's not smooth. Up, droop. Now, yes, there's other stuff going on here, like where the heck is my disc space in this area, right? Where the heck is I see it here, disc space, and then like it's like gone. So this patient is, like I said, they're having some cervical spine arthritis, degenerative disc disease, that kind of thing. But this is just going to show you why those lines are important. It helps you kind of pull out some of those abnormalities. But now we're going to talk about spinal stenosis. So what is spinal stenosis? Narrowing the spinal canal. Simple as that. It's stenosing. Why? There's lots of different reasons it could be doing it, right? It could be from osteophytes, like we just talked about. I mean, this is the anterior, but if they were posterior, it could be from the osteophytes. It could be from spondylolisthesis. We'll look at what that is. It could be from a bulging disc or a herniated disc. Interchangeable terms from this course: bulging disc, herniated disc, right? They're most common in the cervical and lumbar regions. Often have constant back pain. Right, I know we're in the cervical area, but this kind of plays into lumbar and cervical, which is why we're talking about back pain, neck pain, why thigh and leg stiffness is in there, because this commonly happens in the lumbar as well. Has that radicular pain, because a lot of times that bulging or that stenosing is pinching on either parts of the spinal cord, parts of the nerve roots, maybe parts of the actual like sciatic nerve or those kinds of areas, and that can be causing issues. We often obtain an x-ray first. Right, x-ray first, because we want to see loans and see if there's any kind of abnormalities there. But then your MRI is your study of choice for spinal stenosis. Why is our MRI the study of choice for spinal stenosis? Because I want to see if that spinal canal has any type of constriction to it. I'll also be able to see if any of those intervertebral discs are herniated or bulging posteriorly into that spinal canal. That's why the MRI is the study of choice for spinal stenosis. I can see the spondylolisthesis and the osteophytes on x-ray. So sometimes I don't have to get the MRI if the x-ray gives me an answer for the condition, but if I'm not sure or it's not clear, then an MRI is my study of choice. Two different groups that cause it, kind of briefly talked about it already. You got your bony structures, and you got your soft tissue structures. The bony structures are going to be osteophytes, or spondylolisthesis, which we'll look at. Your soft tissue structures are your herniated or bulging discs. Sure, these can all cause it too. I'm not covering that. We're covering herniated discs, right? But you can have hypertrophy of the ligamentum flavum. It's fun to say. I've never seen synovial facet cyst or epidural lipomatosis, but those are things that can absolutely happen. Lipomatosis, basically fat collection sitting in the epidural. Anything that's soft tissue that is sitting where it's not supposed to be in the spinal canal, causing a narrowing of it or a constricture, is a cause of spinal stenosis. We're going to focus mostly on herniated and bulging discs in that area. But here is an example of what I was telling you, that cervical spine arthritis, right? These are supposed to be the neuroforamen, the ends. You can kind of make out some of these nice open areas on these oblique ones, particularly the two lower ends. But then look at the one the black and white arrow is pointing to. It's like that big. I got osteophytes coming in here, osteophytes coming in here, right? It's much more narrow and much smaller than my other ones that look normal. And I got osteophytes on the anterior portion here of my vertebrae with the dotted arrow. Right? I draw my line down, it kind of comes down, and then like, what is that? And then it's like over here. So like that is an issue. So these are all signs, okay, of your degenerative disc disease, and this can lead to any kind of spinal stenosis or narrowing in that area. Spondylolisthesis. Spondylolisthesis. I said it right most of the time. Slip of a vertebral body relative to the one below. So this is where we draw those lines. Remember how I said I don't want to draw a line and have like a little stepwise in? Here's my normal, nice pretty line all the way down. Now when I come down here, I come down and I come in a little bit and then go back down. Right? In and come back down. Does everybody see how that top vertebrae is starting to slip down over the one underneath it? So if I were to count this, I would go 1, 2, 3, 4, 5, 6, 7. So I'm involving 1, 2, 3, 4, 5, 6, 7. We involve the two vertebrae that are affected, so C6, C7, right? Because the slippage is starting with 6. And then literally, unlike everything else we talked about in this block, the direction of this is named for the movement of the superior vertebrae. Everything else has been distal. Spondylolisthesis is named for the superior. So this would be a C6, C7 anterior spondylolisthesis. We name the two vertebrae involved, and then the direction is based off of the superior vertebrae of the two that are involved. Because what the intent is usually is that this stuff rarely goes back. When the vertebrae sit, the superior one is the one that's moving a certain direction. The bottom's not moving, right? And what happens is all of these guys above it are gonna follow. When this shifts, all of them shift with it because they're all connected. They're gonna follow. So we're gonna have more practice at this, but we name it for the two vertebrae that are involved, so C6, C7, the direction that the superior segment goes, so anterior spondylolisthesis. This is where having to be able to know how to number the vertebrae becomes important, because you can call this just by counting them yourself. Questions on that concept? We will see more of this in the lumbar spine because it is more common in the lumbar spine. So we will have more practice with images of counting them and naming them and all of that in the lumbar spine. Just don't get it confused because it is different. Everything else we talked about was named for the direction of the distal segment, the distal portion of the dislocation, the distal portion of the fracture of the displacement. This is named for the superior vertebrae direction. Degenerative disc disease. Said it multiple times already, here's the actual slide on it. Radicular pain, stiffness, pain, or no symptoms, right? This can be an incidental finding. Somebody comes in because they tweak their back, you're 100%, you're like 98% sure that it's muscular because you push on the paravertebral muscles and oh, it hurts right there, or it hurts in the sternocleidomastoid muscles or the scalenes or whatever. You're like, this is musculature, but you know what? You're a little bit older. Let's make sure there's anything crazy going on there. We'll go order X-ray just in case we don't miss anything. You find degenerative disc disease, it does not always mean it's the cause of the pain. If you believed it was muscular before you got the X-ray, because of your physical exam, stick with muscular in your treatment plan. Just inform them they have degenerative disc disease, and please don't freak them out. When you tell them these words, they get freaked out. Give them the layman's terms. It's basically just arthritis of your spine. If you're 70, we expect this. Heck, and some people in their mid-50s, we expect this, right? It's degenerative disc disease is big fancy medical words for arthritis of your spine. You're getting those osteophytes, you're getting that inflammation, it's gonna be painful to do certain things. X-ray is your initial study and your study of choice. Why? Because it's like an arthritis, right? Don't get confused because it's a disc disease thinking I need to get an MRI. It's not. This is x-ray. It's for the spine. It's due to the osteophytes. Okay? Yes, MRI can add more definition and detail if for whatever reason you're concerned about impingement or anything along those lines, or a disc herniation or things like that, but that is separate from the actual degenerative disc disease. Those are two different things. You do not need an MRI to diagnose this, just the x-ray. Okay. So, a couple of ways we can notice some of these things, right? Again, just like in our knees and with our other arthritises, we have loss of joint space, right? We get that inflammation, we get those osteophytes, we get that loss of joint space. What did we say the, which part of the spine had the largest space in between the vertebrae? The lumbar, right? What is going on between L5 and S1 right here? Look at how thin and small that is, especially compared to the vertebrae above it, right? The same thing happens in the spine with degenerative disc disease. That disc space degenerates, right? We get the osteophytes, we get the inflammation, it gets narrower than it's supposed to, and that's what can cause some of the pain. You lose that range of motion, you also lose some of the disc height in there, you get those osteophytes. It's the same as those other arthritis we talked about in the knee joint or the hip joint or anything along those lines. That's why that layman's term is, it's arthritis of your spine. Helps the patients really understand what's going on. Questions on the degenerative disc disease? Do not get confused and just because disc is in the title and think you need an MRI. X-ray is your initial and study of choice. Okay. Compression fractures. Another one of these fun things that is women more than men. Why? Osteoporosis. Osteoporosis. Fine. Another thing that could be asymptomatic or could cause pain. Great. Now I don't have a symptom to kind of go along with it, right? X-ray is going to be your initial study. Okay? Now this is unique. We talked about osteoporosis. We know about the DEXA scan to evaluate the osteoporosis. X-ray is my initial study, so that kind of goes along with that. But MRI is my study of choice. Why? Well, it's right there. It's not to evaluate the compression fracture. It's if we're not sure if the compression fracture was caused by osteoporosis or if there's a malignancy in there. So the MRI will help us pull out whether or not there's a malignancy or some type of mass, cancer, tumor, something along those lines that's not supposed to be there that maybe doesn't show up on x-ray because, what is that? It's soft tissue. So I may not see it on an x-ray. So if I have a patient that the rest of the x-ray doesn't look osteoporotic or they don't fit the osteoporosis kind of profile or they have no history of it, like they've been, let's say they had a DEXA scan 3 months ago, it was normal, so they're not osteoporotic, but they have a compression fracture. Now I'm jumping to my MRI to figure out what else is going on in that spine. Why do you have a compression fracture? Because this is primarily due to a loss of density of that vertebrae and the weight just kind of compressing it and kind of squishing it down. Okay? Most oftenly in the anterior superior portion of the vertebral body, this area right here in the white arrow. Most oftenly in the anterior superior portion of the vertebral body. This is where my compression fractures are. And it's literally just looking at a vertebrae and it's just compressed down. Vertebrae should be nice and square or rectangular in shape, and you have that anterior superior portion that's just kind of compressed down. It almost looks like if you needed to, you just walked up there and just kind of pinched it, and pinched that top part down like it was Play-Doh. Yes, sir?
Is the bone eroded or is it just, is actually?
So what's happening is there's a loss of density in that bone, so it doesn't erode, it just compresses on itself from the weight. So that's why it's mostly osteoporosis. So we lose density in the main body of the vertebrae, and then because it's not as strong as it used to be, it just... We can see them in the thoracic spine, we can see them in the cervical spine, right? The lower you go, the more common they can get. Because again, the lower you go, the more weight you have on your spine. Here's one on a CT. Compressed right there in that area. Let's see which one. C1, C2, C3, C4, C5, compression fracture of C6. See how I counted that? 1, 2, right? Why does this not look like it's separated up here? Because again, that C1, C2 kind of come together with the lateral masses, the body of C2 and that gangs that comes up. So they kind of come together in this area, so there's not always that nice, beautiful disc in there. So 1, 2, 3, 4, 5, 6. Yes.
So are we visualizing like a chunk in the
You
middle
are.
there?
I was getting there, yeah, right there. So that is sitting in the spinal canal. So now we also have spinal stenosis because I have a fleck of bone from this fracture sitting in there.
Sorry, can you count one?
Absolutely. Here's my spinal process, right? So 1, 2, 3, 4, 5, 6. Bam.
So the compression, or the compression is on the front half and then the stenosis is the back portion.
Correct. Correct. Two separate things going on here, right? Because spinal stenosis is anything that's narrowing that spinal canal area. Also have the compression fracture on the vertebrae. Compression fractures do not often have, there's good English for you, do not often. Compression fractures often do not have a particular trauma or injury associated with it, right? This is chronic pain, long-term pain. They're finally coming in for something. You get an x-ray, you notice they're osteoporotic, they have a compression fracture. There's not a mechanism of injury that is normally associated with this. Again, I don't use always and never in medicine, just giving you generalities, right? Questions on the compression fractures? Ironically, compression fractures, I mean, one other thing, what do you think compression fractures could potentially lead to? Something we already briefly talked about. The spondylolisthesis, right? Because if I have those vertebrae that are sitting like that, and they're supporting one another, and all of a sudden one of them goes like this, now the one above it, it's a lot easier for it to slip forward because it's not sitting, doesn't have the support that it should right here. So for this guy, if that's C2, 3, 4, and 5, I would be concerned about eventually C4 slipping anteriorly here because it doesn't have that support anymore on the top of that vertebrae. We see that more often in the lumbar because of the extra weight, and we'll look at some of those. But understand, compression fractures can lead to a spondylolisthesis, or what I'm trying to tell you is you can have both abnormalities on the same x-ray. You don't just have to have one, yes.
So with the spondylolisthesis, if you're gonna annotate that with compression fracture, would it be C5, 6, and 7 since?
Yeah, good question, right? So what I would call in this one, so C2, C3, C4, C5. So if, and this one doesn't have it, right, they're lined up. So if I had the spondylolisthesis on this one, 2, 3, 4, 5, I would say I have a C5 compression fracture, and then C4, C5, whatever direction spondylolisthesis, right? Still the two vertebrae affected, and then you name it from the direction of the superior vertebrae, which way is it going? Don't have it here, so I don't have a way to name it, because really this line, if I were to take that vertebrae and draw it where it's supposed to be, my anterior cervical line is good. It's where it should be. I'm imagining as if the bone was there. We'll look at that with the lumbar. But herniated discs. Okay? Spine, cervical, or lumbar, whatever it is the initial study, always for all this stuff, because what if it's not a herniated disc? What if there's a bony abnormality, like that last one where it had the fracture, it had something sitting in the spinal canal area? MRI is your study of choice. Why? Because we haven't been able to see the discs unless we do an MRI. We can't see the CSF in the spinal cord without doing the MRI. And you'll see what these abnormalities look like on MRI. This is the one MRI I would expect you guys to be able to dictate, read, and find the abnormality. And you'll see why here in a second. Primarily though, these patients are going to have pain, back tightness, but the biggest thing is the radicular symptoms following a dermatomal pattern. Yes, those dermatomes are teaching you guys in clin skills, they matter. They give you information. If you're getting that neuropathic pain, that radicular pain in a certain area of the thigh or a certain area of the leg, you can already have a suspicion based off of what dermatome that is, of where you might be finding your herniated disc. Whether it's through the nerve root or whether it's through the main spinal canal. Here's the fun part. Everybody wants an MRI. I have low back pain. I need an MRI. I think I have a herniated disc. 2% of back pain is due to a herniated disc. Because you're going to get MRIs and you're going to see small herniations that aren't, or small bulging that isn't big enough to cause any pain. But the patient's going to be like, that's why. I knew it. So when should you order an MRI? You should order an MRI if off of your physical exam and findings, you're concerned about a herniated disc, sure. But in general, shoulders, knees, all that stuff, if your physical exam findings have found something that you suspect something that is surgical in nature, a meniscal tear, an ACL tear, a labral tear, a herniated disc, something along those lines, order the MRI. And you can use that same logic to talk your patients out of the MRI. They don't realize that MRIs are majority for surgical planning when it comes to musculoskeletal stuff. They don't know that. So you're like, oh, do you need surgery? You want surgery? No, I don't want surgery. Okay, well, the only reason they get an MRI is if we think you might need surgery. And based off of the special tests I did on your shoulder, I don't think there's any labral pathology, so I don't think we need an MRI, so we're gonna go with physical therapy and do X, Y, and Z. Patients are much more apt to accept your no to their MRI if you explain it in logical terms what your thought process is, instead of just no, you can't have one. Because they spent years being told no by their medical providers without any explanation. And that is one of the things I think that sets us apart from the other practitioners, is you take the time to explain to our patients why we're doing what we're doing or why we're not doing what we're doing. Patients are way happier if they know why, as opposed to you just saying, no, you can't have this. So, use that. Off my soapbox for MRIs, just trying to help you guys out. So, okay. So most often occurs in the lumbar region, right? You can have it in the lower cervical spine. Very rarely do you get it in the thoracic spine. Why do we think we don't have a lot of herniated discs in the thoracic spine? Ribs. For those of you who said ribs before that, say it louder. Right? The ribs help support the spine and help keep it where it's supposed to go. And it also helps kind of, the thorax helps take some of that weight off that thoracic spine. So we have less just free weight going on that spine to be able to cause the herniated disc. So it's really rare to have one in the thoracic spine because of the thorax and the rib cage. Alright. So here's what it looks like. Big yellow arrow sign. On the test you won't have a yellow arrow sign. But what stands out to me when I go through this, right? I follow my spine all the way down. Let's pretend like the tools I've taught you for x-ray and everything too. I'm also following my CSF down. Does it look the same all the way down? It should, but it doesn't. It almost looks like I have this pinch here to where I can't see my cerebral spinal fluid sitting right there. Right? Because that disc is protruding posteriorly. Now, is it a herniation full on? Like, is the actual nucleus pulposus leading the annual fibrosis? Or is it just a bulge? I don't know. I don't care because I have the disc herniation or disc bulge right there. You can use them interchangeably when talking about images because it doesn't really matter what's happening right now, if it is fully herniated or just bulging because we're causing symptoms. Yes, sir?
So is it starting higher up too? I can see like
Right here?
Yeah.
A little bit, yeah, good eye. So for those that are looking, right, it does look like we might have another small one here. And that small one up there is what I was telling you about, right? That's the one that's not causing any issues. It's barely pressing on the cerebral spinal fluid. It's not touching the spine at all. But when you order the MRI and the patient sees that, they'll be like, that's it, I told you this is where my pain's at. That's not causing the issues. So how you word that to the patient is like, hey, there is a small disc bulge at, we'll say C2, C3 or whatever, but it's not severe enough to be causing your pain. That's not causing your pain. It's not impinging on anything there. And that's the danger you run with these things sometimes. But yes, it is there. Yes, sir.
It looks like there's something in the disc space below that.
Right here?
Yes, sir.
That is actually just the disc. So if you look above it too, you can kind of see it just a little bit there. If you go back to some of our other, and look at my normal over here, right? Disc space, That's my actual disc. So on some of them, they're dense enough to where you can actually make out the intervertebral disc in between the vertebrae. It's gonna depend on technique or not. So that's why on these, what we're really looking for is looking for any of that posterior protrusion. Again, more common in the lumbar, we'll look at lots of lumbar ones as well. So this is why I say this would be the only MRI I would make you kind of find the abnormality on, because if you just follow it down, you can look and see where it's at. Okay. Here's another one in the lumbar spine. So this right here, this area, these are just, see how it's closer up now so I get a better visualization? These are my intervertebral discs. But I have a small bulge right here. This is not causing that patient any back pain whatsoever. This here. But the advanced pupil radiologists will be able to look at the nerve roots that are sitting in here, and I can't really quite see it there, and see if the nerve roots are impinged. You guys won't have to pull that out. Radiologists will do that. But does everybody see the L4, L5 bulge sitting right in there where the yellow line is? It's subtle, but if I follow it all the way down, I can see that bulge sitting there. All right. That's just a really bad picture of those anterior osteophytes in the cervical spine. What do we got going on here? Compression fracture. Good. Notice how the bottom of the vertebrae looks pretty normal. I don't have any major issues with that. But then up here, I'm smushed down a little bit. Look at the size of my vertebrae on all the other ones. And then this one is shorter, smaller. Got that compression fracture. Definitely osteoporotic, right? Look at the radiolucency of the vertebrae. Look how dark they are compared to maybe like the sacrum or some of the healthy lumbar spine we've looked at. It's almost the same density as the soft tissue area, and I can just make out the cortex of the vertebrae. So this is definitely a patient with osteoporosis as one of those signs. And we'll look at that again when we get to the lumbar spine section here to talk about the difference between the two. Yes, sir, what's your question?
I was gonna ask you, based on that, if it was osteoporosis.
Yes, yeah. Hard to really see on the AP, right? And that's why I got that in there. It's the same patient. Really hard to make that out, and that's where that lateral really comes into play. But when you order a lumbar spine, you're gonna get both. You don't have to worry about ordering one or the other. Both are standard. Okay. So what do we got here? Spondylolisthesis. Okay, so in your head, don't do it out loud. Start counting. Try to name it for yourself. I'll give you about 15 seconds or so, 15, 20 seconds to go through it. And then I will do it with you. All right. Base of the skull up here. Base of the skull. So here's my first one. So C1, C2, C3, C4, C5, C6. C1, C2, C3, C4, C5, C6. So this would be a C5, C6 anterior spondylolisthesis. Right? But you see what I was talking about earlier? Here's C6. This is supposed to be C7. Bless you. I can barely make that out in T1. That's why with the laterals we count from the top down, because depending on the patient, all that shoulder or soft tissue, you might not be able to make out that full cervical spine. So we start up here. So C5, C6 anterior spondylolisthesis. If you didn't get it, don't worry about it. We'll have more practice at this, and you'll get better at it. Like right here. Well, why do we name this one? We didn't talk about how to count for the lumbar yet, but let's see if you can figure it out. Particularly on the lateral. All right. So what do you you think my point of origin I'm gonna use for counting on this one is? Sacrum. Here's my sacrum. So L5, L4, L3, L2, L1. Sacrum, L5, L4. So L4, L5, anterior spondylolisthesis. Same thing here. Sacrum, L5, L4, L3. L4, L5. Sacrum, L5, L4. So L4, L5, anterior spondylolisthesis. Yes, sir?
Is that also degenerative disc in the thoracic region?
Like here? Right here? Yeah, I see some osteophytes there. I'd buy some possible degenerative disc disease in the lower thoracic. Yeah, same thing.
That's why I got distracted.
Yeah. Remember, don't let the shiny toy get you. And how do you know if I'm looking for degenerative disc disease or a spondylolisthesis? Read the question, read the answers, then figure out what I'm asking you to look for. Because again, finding x-rays, it's a little bit easier when we're looking at certain kinds of fractures that we've talked about, right? But when we're dealing with spine, and particularly next block with the chest, finding x-rays with just one abnormality is very, very difficult to do. Because a lot of these patients are older, they're injured, they're sick, something like that's going on. So trying to find just the one to be able to test you guys on is hard. So what I have to do is get that image, ask you a specific question, and make sure that those other findings, like if I wanted you to get the spondylolisthesis, I couldn't make thoracic degenerative disc disease an answer in this particular question, right? Unless I asked you specifically for lumbar pathology, right? I couldn't do that. So I would have to make sure that that is not an answer choice when I'm trying to get you guys to go down here. Because if I did, technically they're both right. If the question is just what's the abnormality? Which means dual credit, which I don't like doing that. I want to give you guys a valid test. All right. Questions on the cervical spine? Yes, sir.
I think for kind of both of these, is there any clinical value in the patient positioning, like supine versus standing, load bearing, something like that?
Yeah, not necessarily. Most of your spine x-rays, it's gonna depend on the patient. Most of your spine x-rays are done lying down. Unlike the knee and like the ankle and stuff like that, because of the discs, there's not really a huge benefit to making sure they're weight bearing. So normally it's just gonna be a lying down one, that's the standard protocol. Yeah, good question. Anything else on cervical spine? The thoracic is a lot easier. There's all your thoracic spines. Your vertebrae, know your anatomy, know the muscles. Most of the stuff is muscular related. Here are your normal radiographs. I have good news for you. If I want you to name something on the thoracic spine, I will label it. There are no good, especially for the lateral, there are no good ways for me to tell you, hey, this is where T12 is and L1 and all that on the lateral, so I will label it for you if I need you to pick out a specific vertebrae on the thoracic spine with a lateral image. Now with the AP, I could do, because all the thoracic spines have, or vertebrae have what attached to them? Ribs. So at the very bottom, you see one with ribs, and the one below it doesn't have ribs. Well, that's T12 and L1, and from there you could count up, right? But I didn't give you a vertebrae on this picture without ribs. So how are you supposed to know that's 12? Right? You're not. So I would have to give you that to do that, but as far as counting lateral, it's too difficult. I'm not gonna make you do that. But you can still do your lines that we talked about, right? Your anterior vertebral body, posterior vertebral body. You know, you just instead of the spinous process line, you can just do your ribs kind of coming down here. Yeah, sorry, your spinal laminar. The spinous process still comes down here. And you can still do your lines. You can still do the two lines here on the A and P if you want to. So you still do all of those lines to make sure everything's in alignment. You still see your disc spaces, not your discs, but your disc spaces. Okay. And then we get our CT. Our CT evaluates our thoracic spine a lot more. There's not a whole lot of thoracic abnormalities that we're going to find on x-ray outside of your compression fractures, a burst fracture we'll talk about, certain kinds of fractures in the vertebrae. But you don't get a whole lot of disc herniation or anything. But here is a CT. So what slice is this? Sagittal. What's this one? Coronal. Good. Good. What are these guys? Kidneys, liver, spleen, yay. More block 2, but good to know where we're at, right? So there's your thoracic vertebrae. We'll do a CT on a lot of the stuff. We gave contrast to this patient because the aorta is highlighted and so are the kidneys. So you can tell there's contrast. If not, they would all be the same density, the same gray color, right? MRI versus CT. Again, look at your CT. Look at the spinal canal. It's all gray. It's all the same density. I jump to my MRI. All of a sudden now, I can make out my spinal cord. I can make out each of the intervertebral discs. This is a better one for the one back there. You can really see the discs really well on this particular one, the thoracic. That's usually what that is. So there's another one kind of matching up and being able to look for any of those disc bulges, even though they're super rare in the thoracic spine. This is something we can diagnose with the thoracic spine X-ray. What is that? Scoliosis. What are we going to do for that? Refer. You're ready for family practice. Don't refer. What's that? Does anybody know? So it depends. It depends on the degree of angulation. There's something you'll learn about called cob angle later down the road. It depends on age and angulation, on whether or not we do anything for this. A lot of times, if it's a kid through puberty, we're going to let them do their thing and see if they kind of straighten out. But I'm probably wrong on some of this, but don't worry, you'll hear about it in the senior semester. But there's an angulation. They could surgically fix it, depending, right? So my son right now is dealing with a level of scoliosis and pectus excavatum, and we're waiting to see once he's done with puberty how severe it is to figure out if he's going to need to get fixed or not. So it's just going to depend on symptoms, the patient, and kind of what's going on. But this can cause some significant pain, right? So if you have patients who are experiencing pain and they have scoliosis, give them the physical therapy. A lot of times it's just working on the muscles and kind of getting them stretched out and strengthened, so that way it doesn't cause too much pain for them. But okay, what's this abnormality? Positive yellow arrow sign. That's not the diagnosis. Compression fracture, right? Shortened vertebrae compared to the other ones. Coming in there. Doesn't look like a little bit on the bottom too, but coming in there. And then therefore a disease process is most likely osteoporosis. I like this slide because I want you to look at the brightness of the normal CT compared to the one with the compression fracture. Now that I have them side by side, do you see the difference in the densities of those vertebral bodies for the patient that is healthy versus the one that has osteoporosis? And you're sitting there going, how am I going to pick that out if I have just this one? Looking at lots of normals, understanding what it looks like, what it should look like, and then use your patient vignettes. If this is a 23-year-old male, I'm probably not convinced it's osteoporosis, and I'm concerned that if I have a compression fracture, that it may be a malignancy, so then I would jump to the MRI. But if this is a 72-year-old female, then it kind of fits with everything we've talked about, and I can move on with life. Does that make sense? So I like this one because it shows the two densities together. And then we run into our burst fracture. Yeah, I hate to see it too. Right? High energy fracture, usually MVAs. Usually motor vehicle collisions, MVCs, motor vehicle accident, whatever you want to abbreviate it as. So these are going to be your high energy fractures of your vertebrae. Not always in the thoracic, but very commonly in the thoracic. Seatbelt comes across there. A lot of pressure from that kind of stuff. Like high likelihood of spinal cord injury because these fragments can just shoot right into the posterior segments of the spinal canal and get in there and cause that. But you can see how it's comminuted, right? Most of our compression fractures, except for that one we saw, but most of that compression fractures kind of stay in one piece and just compress down a little bit. This is multiple pieces. Anterior, main vertebrae, posterior, and it goes along with the mechanism of injury of that high energy impact, that high high energy injury. Whereas again, that compression fracture, we don't need that type of impact. That's something over the course of time from the low density. So that burst fracture is gonna be that high energy type stuff. You may or may not have neurological deficits. May or may not. So what are these? Compression fractures caused by osteoporosis. Okay. Burst fracture. Not osteoporotic, right? Another thing to look at. Look at my spine. This was my normal. Look at my CT for my osteoporosis patient. Look at my CT for my non-osteoporotic patient. Okay. T6, T7, so like if I were to want you to pull out a disc bulge on something like this, I would take away the arrow and label the vertebrae for the thoracic spine. Okay? I do not expect you to count, so don't spend any brain power doing it when you're studying the thoracic spine vertebrae on a lateral image. So this would be a T6, T7 posterior disc bulge. And yes, for those of you that are looking, there are some tiny ones at T10, T11, and a little bit of T11, T12.
On the test, you wouldn't say herniated, you would just say disc bulge?
Either, it would be one or the other. Herniated disc or bulging disc, for this course, one and the same. Yeah, good question. If there's bulge and herniated on there, which they really shouldn't be in the same one, it's not trying to trick you, they're the same. Pay attention to the locations, that's where the real answer is.
Just trying to understand the language.
Yeah, no, you're good. Yeah, and because that's the problem, right? Is because technically a bulge is just a bulge, right? It's the annular fibrosis kind of bulging out. The herniation is when that nucleus pulposus comes out of the annular fibrosis, and that's what the herniation is. When on imaging, I have no idea. There's just pressure there, so they're kind of used interchangeably when we're talking about it from an imaging standpoint. Sure.
Yes, so I'm like an exam, you're asking us what stuff about one of those, would that Walmart be something that shoots into the spinal cord capacity,
If I were to give you something like this and I wanted you to pick it out, I could not give you T10 and 11 and T11 and 12 as a choice, along with T6, T7, because technically all three are there, right? So if I gave you this image, all of my choices, I would have to have only one that is absolutely correct, and the other four would be things like T3, T4, T4, T5, T8, T9, ones where there aren't any. Yeah. Whew. Skull, brain bleeds, facial bones, orbital fractures, cervical spine, thoracic spine, compression fracture, burst fracture, bulging discs. And since I came early, we still got 30 minutes, so I'm just kidding. Any questions on today? No? Alright, so here's the deal. Here's what I'm going to ask of you. You guys have a test on Friday? No. Okay. I see you again on Friday. I know you got a lot of things. What's your first test? Is that Monday is your first test? Farm. I know you're going to spend a lot of time on farm. I get it. It's farm. You're going to. Please, over the next 3 days, for Friday, carve out some time to look over this stuff, right? Because I'm telling you, once we get into that upper and lower extremity, it goes pretty quick, because we already belabored a lot of these abnormalities. Spend a little bit of time just looking at it. Not necessarily, if you're not going to commit to memory to be like, I know it, I'm ready to take the test on these slide decks. At least the area where you know the things that are challenging you, the things that you're having a hard time grasping. So you can write that stuff down and get it ready to go to tee it up for me for questions on break, before class, after class. But please don't ignore it, because this test isn't for another 2 weeks and we're almost done with the material, right? And I don't want you to wait until that time. So, carve out a little time for me, yeah.
As far as the studying goes, I know you gave us lots of resources for other pictures. For this first initial, I would say first pass for most of us, do you think we should focus just on slide pictures?
Yeah.
Or should we start diving into those third-party pictures?
Until you understand the concepts, stick with the slides. Once you feel confident, if you understand it from the slides, start getting into the Radiopedia pictures specifically with the names of stuff. To go, got it, see it, looks a little different, but I see it and I got it, right? If you try to go to the Radiopedia and start to look at things like psoriatic arthritis, without having a grasp of the slides I've given you, it's gonna send you down a spiral, right? Because you don't know what you're looking for yet, and they're all gonna look just a little bit different, and then you're like, I just don't understand what's going on here. So once you have a slide grasp, then jump into those third party images. Yeah, other questions? Thanks for bearing, oh, yeah.
On the exam, are we allowed to bring a white sheet and then just turn on it and draw on it, or the images?
I don't know. Nobody's ever asked me that before. So like, you mean like put a blank piece of paper on your screen and
So I
like
can
draw?